Hi, my name is Megan Michelson, and this discussion is about operating room scheduling and the use of machine learning to improve scheduling accuracy. So current practices in OR scheduling typically depend on the surgeon's estimates of surgical time. It might be that the surgeon writes in their preferences how much time they need for the surgery, or that the scheduler has a list of approximate times that the surgeon needs. But these are based off of the surgeon's self-reported times. Because of this, the times are based on the procedure and not individualized based on the patient's history. They may not account for extra time needed for anesthesia induction, anesthesia emergence, or positioning, and over or underestimation of these times can affect OR costs. Some other options may be that the scheduler can use an estimate based on the surgeon's average. Positioning times could be based on the stated position of preference, but again, this doesn't take any sort of modifications into consideration. For example, a shoulder arthroscopy would be listed as lateral, but there's extra time for the patient's arm to be put into a lateral shoulder holder with traction, which wouldn't be accounted for just based off of a lateral position. And estimates could also be made based on average anesthesia start to end times. However, these times don't reflect proper surgical times, as every patient's anesthetic time can be different. Some patients are more difficult to intubate or may take longer to put under anesthesia. The positioning also occurs after anesthesia times, but before the surgeon's times, and the surgeon's reported times are based off the procedure start to procedure end times, so also do not account for positioning times. So all of these current options have some flaws that allow for errors in scheduling, which decreases operating room efficiency. If we use machine learning for surgical scheduling, the artificial intelligence can analyze vast quantities of data, more so than what the surgeon or the scheduler can look at. They can take into effect patient-specific modifiers, such as the patient's weight, which may have a bearing on positioning time or anesthesia times, their comorbidities, if they have certain heart conditions that we may have to be more careful with anesthesia and may take longer to put them under, or that can affect the kind of anesthesia. The machine learning program may pick up the fact that this patient's not a good candidate for general, which the surgeon thought that they were, but the anesthesiologist decides that monitored anesthesia care is better. This is a different induction time and would not be accounted for in the original posting. There's history that may affect anesthesia induction, such as a history of obstructive sleep apnea. Use of a GlideScope, which is a camera-assisted intubation device, takes a little bit longer than normal intubation, and some surgeons, because of the way that this is managed, might prefer to try a normal intubation first, which would again add to time if they had to switch to a GlideScope in the middle of induction. And this can also account for surgeon modifiers, such as a surgeon that works faster in the morning or a surgeon that works faster in the evening, as well as the fact that maybe after a night call shift, a specific surgeon has an average 5-minute increase in their case times. The machine learning program would be able to track these trends and actually adjust surgical times. In order for machine learning to be accurate, it relies heavily on data input, so charting the times is essential. The normal times would be room entry and room exit, anesthesia start and end, and procedure start and end, which is typically the time of incision until the time that the dressing is finished being applied. Times can be added as well for the time that the surgeon or anesthesiologist arrived at the room or the time the room setup was completed, and this can help tracking deviations for delays that aren't anticipated by the machine learning program, so that it doesn't include these deviations in its normal programming. The accurate scheduling can help reduce OR costs because overestimates of surgical time can lead for procedures to end earlier than scheduled, in which case the staff is waiting for the next patient to be ready, but we're still paying that staff, and the room is sitting empty instead of being used for other procedures, affecting overhead costs. Underestimation of surgical times mean procedures end later than scheduled, which leaves the room running later in the day. Staff need to stay late and end up getting call pay or possibly overtime pay. Overhead increases as the room is used longer than anticipated, and patients are dissatisfied due to long waits. So, current practices are not properly customized to the individual, but the machine learning program can properly analyze these trends and lead to increased efficiency and therefore decreased operating room costs. And here are my references.